Welcome to Rural Health Today. I'm JJ Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. Shifting to another topic that's very important and one that you fought yourself is the issue of staffing ratios. And you gathered a team of phenomenal leaders from your organization that really took on the legislature with this and did a lot of advocacy, including yourself with testimony and other things. Talk to us a little bit about the dangers of staffing ratios. Are they important for hospitals? Are they not important? Should we have them? Should there be limits?
Well, this is an issue that is front and center all across America right now. And in fact, it's front and center at the federal level with the current proposal to implement staffing ratios in skilled nursing facilities.
Mm-hmm.
And fortunately, we believe that either Congress or the Trump administration is going to unwind that Biden-era proposal. But to come back to the Michigan situation, JJ, as you alluded to, for the last couple of years, we had legislation that had been introduced. It was the subject of a hearing in the House Health Policy Committee.
Yeah.
So this had traction.
It had a lot of traction.
Labor unions were pushing this very aggressively. And to your question about are these the right things? Well, we don't have a problem with staffing ratios as long as they're developed at the local level by hospital leadership and chief nursing officers who have access on a daily basis to information like the acuity level of the patients in-house, the training of the staff in-house, the technology that you may or may not have, the ebbs and flows seasonally, which is an issue in a lot of rural communities for sure. And you can make that decision on appropriate staffing levels unit to unit, shift to shift, day to day.
That's right.
Right? And that's happened for years. What we're talking about here is replacing all of that local expertise with a government-mandated one-size-fits-all approach, which we have argued does not make any sense at all. No. Unfortunately, our colleagues in Lansing, for the most part, agreed with that. And as you saw, despite a real challenge during the lame duck session at the end of last year, we were successful and we prevailed and were able to
You did
curtail
prevail,
that.
Brian, without your leadership, and I say this wholeheartedly, without your leadership in the work of MHA, I would be staring down some very difficult decisions of hospital closure, not being dramatic. The reality is that I can't even hire nurses right now. There's a nurse shortage in this country, especially for rural hospitals. And so the challenges would have been overwhelming for hospitals like Hillsdale because we just didn't have the bandwidth, the staff, the recruitment opportunities. And then, Brian, let's talk about there's not enough nurses to go around.
That's right. And this was really the most compelling argument in our advocacy, both the testimony, but also all of the one-on-one conversations we had with elected officials, and certainly the site visits that we helped to facilitate, where the story was told exactly as you just shared, JJ. Here's the real impact that this would have. And the impact is going to be lack of access to care, because our hospitals, when they are not able to meet the letter of that new law, they are going to be forced to close down or restrict certain service lines. They're going to be forced to say, sorry, no room at the inn, because if we accept that next patient, we could run afoul of the law, and now we have licensure considerations to deal with. We have financial penalties to deal with, all the rest. And so we portrayed this accurately, in my opinion, as a real threat to patient access. You're exactly right. We have a nurse shortage. It's hopefully going to improve over time as we train more nurses with the public policy change in Michigan that we've accomplished and with new funding. But this is not an issue that gets resolved in the short term.
It is not.
This is going to take years to address. We hope new technology is going to be part of that as a force multiplier. So there's some things to be excited about.
I agree.
But we have to deal with the here and now.
Absolutely.
And to foist this sort of ill-conceived legislation on hospitals that are already struggling.
Irresponsible.
It would have been irresponsible. Yeah. And fortunately, as I said, our elected officials agreed, and we live to fight another day.
We do. Well, prediction. I want your prediction. Nationally, a lot of us that are, with nursing homes, and this podcast reaches every state. those folks that are faced with the challenges of nursing home staffing ratios. Is it going to pass?
So here's my sense. Now, as a result of the November election, we have a Republican administration, of course, in the White House and a Republican Congress, even though that is a very razor-thin margins in the U.S. House and Senate. We are going to unwind that skilled nursing facility staffing mandate. The question is whether that's going to be through an administrative act by the White House and CMS, or whether that's going to be through an act of Congress.
Yeah.
The reason that we actually hope that's an act of Congress is because this actually saves the federal government significant funding if you were to unwind that staffing mandate, which is a good thing because that savings can actually be applied towards these instructions that have been given to the House Energy and Commerce Committee to save all of this money to extend the Trump tax cuts, which of course expire at the end of this calendar year. So, JJ, as you and I have talked over the years, nothing in politics happens in a vacuum.
Never.
You always have to think about the other issues that are in play, either federally or at the state level, and how those impact each other. And this is one of those.
Yeah. Brian, you've been an advocate for professionals practicing at what we call the top of their license. Talk to us a little bit about that and the work that you've done. And I know in one particular area that's benefited Hillsdale that I can give you, CRNAs. We are not required now to have an anesthesiologist here, which I cannot, by the way, afford to hire 5 anesthesiologists. But I can hire CRNAs who are great in their field. Talk to us a little bit about the work that you did around that. And it just doesn't involve CRNAs, but that was a piece of legislation I know MHA was very, very closely involved with.
We were, and we were really focused on creating opportunities for our rural hospitals in particular to continue to provide access in their communities, because under the old model, there was always this looming threat that if you were to provide care, even emergent care to a patient, but you didn't have that anesthesiologist on call on site, that you were going to run afoul of the law and all of the repercussions
Sanctions
there. So this was an access issue. And again, it's not mandating that our hospitals do anything. It's giving you, as you said a moment ago, the flexibility, the opportunity to do what you need to do to provide access in your communities. And that's exactly the way this has played out. There's been no impact on the quality of care. We track that data, as you would imagine. And so this has been a good outcome for Michigan, but particularly for rural Michigan. But this point of practicing at the top of your license, it does go beyond CRNAs. When you think about the shortages in the healthcare workforce writ large, and we project into the future, we understand that so many folks are going to be retiring from their job in hospitals and in nursing homes and other healthcare facilities, and the pipeline that's in place to replace those very critical workers, we need to ensure that public policy supports it in multiple ways. And one of those ways is to make sure that people are practicing at the top of their license. We shouldn't have, for example, RNs, highly trained RNs, that are doing things that that someone who has less training could be doing. That's an ineffective use of their time.
Absolutely.
We can't afford that in this environment.
No.
And so that's why we continue to press on these issues. It's why we also continue to press for Michigan to join the Multi-State Nurse Licensure Compact. We are already part of the Physician Licensure Compact. In fact, that's one of our active advocacy issues right now. That's expiring and needs to be re-upped. It's going to be. There's no controversy there in Lansing on that issue. But there is controversy over the Nurse Licensure Compact. We continue to try to get that to the finish line. There's been pushback. But there are just multifaceted issues here when it comes to healthcare workforce. And this practicing at the top of the license is an important part of that.
It's a critical part. So before we get into the last topic of the day, Medicaid, I want to ask you a question because your job is at times herding cats across every discipline as you look at the work that you're doing to support hospitals. There can be some competing interest because there has to be certain issues that you have to be neutral on. I know I came to you once and I'm like, Brian, I need you to be an advocate for CON. And you're like, JJ, let me talk to you about CON. You taught me a valuable lesson because I was ready, charge hell with a squirt gun. I was ready to go. But to your point, you represent a diverse group of healthcare leaders and systems that have differing views about certain things. Right now, what we're facing is the DEI conversation. The views of Hillsdale are much different than views of others, big systems. But there are certain issues that you yourself have to step away from because you want the members themselves to be represented in unison. And I'm going to let you talk a little bit about that on issues that we all need to be together on. And I'm not dismissing those issues. I'm simply saying there's advocacy points that you have to raise. So how do you balance that? And when are the issues for you like, nope, yes, we can all get around that? And how do you say no to a JJ when I'm like, you need to do this for me?
It's hard to say no to JJ, I can tell you that. No, you raise a great point, and it's something that is top of mind for every association leader, I would say, across the country and across multiple disciplines, not limited to healthcare. And you've served on the MHA Board of Trustees, JJ, and you know that our approach is that we don't have 18-3 votes or 10 to 11 votes.
Never.
We just don't. Our approach is we need to process an issue to the point where we have unanimity from our small rural hospitals, from our big systems, that we can all agree this is our position on the issue, and let's go forward and advocate for that. The reason we do that is if we walk out of there with a divided vote, the risk is I come into the governor's office today and tell them the hospital field's view on this issue is X, followed by some of our members walking into that same room an hour later and saying something very different.
Yeah.
Now, this is not conjecture. This is what actually happens in other states.
Oh, I know that.
I have had conversations with my counterparts where this exact scenario plays out. It's my worst nightmare as an association leader. You never want to see that happen.
No.
And so we're very cautious about coming together. As we talked about earlier, we have 100% of the hospitals and health systems in the MHA membership. So that's the start.
That is.
That doesn't assure that everyone's going to be aligned on all the issues. So that's the second
Nor will
element.
we ever be aligned on all of the issues, right? Do we have to accept that?
So there are some issues reproductive health and gun violence, to raise two hot-button social topics that are always top of mind with Americans and certainly the media. And we have stepped back from those issues and said there's safe space for the association where we can engage and do right by our staff and our communities. But there are also places where, the politics are different enough in our membership and the viewpoints are different enough. That's not our issue. And trust me, we're not going to run out of big picture topics on which we do agree, where we can spend a lot of our time and energy. So let's put our focus there. Yeah. And that's really, as a leader, what I try to do with our board. Sometimes that requires a lot of behind-the-scenes conversations, no question.
Yeah, it was a remarkable conversation that I had about a month ago with another state's, and this was not part of our podcast. As you know, we did the state tour and interviewed all the CEOs of all the associations. It was fun. But this was not part of that podcast. This was just an independent conversation with a friend who belongs on one of the other state association boards. And he started telling the story, Brian, of the dissension and the arguments and the discord among the hospitals in that region, in that specific state. And I thought, sweet baby Jesus, thank God for Brian Peters. Because at the end of the day, we have never, in all of my years of experience, ever left that boardroom with conflicting ideas, comments, texting each other like, could you believe that? We've all been coalesced around the same mission, vision, and values that you've established as a leader. So I want to congratulate you for that. If you're listening today and you're in associations fighting, stop it. We now more than ever must come together unified on important issues that impact all of us. And I would just encourage you to allow your local hospitals to do what they need to do for their respective communities, but come together on the issues that we're all facing on a statewide and a national basis. Okay, that was easy stuff. Now we're going to get into the hardest topic of all. Medicaid.
Let's do it.
A lot of conversation right now in Washington and in Lansing and across respective states, right? States that have expanded Medicaid, states that have sought out special waivers. I'd love to spend an hour and a half talking about Medicaid and the intricacies of it, because every state has a different approach. Tax increments, limits, provider tax, the list goes on and on. But what we do know as of today, sitting in the studio, is that the House of Representatives in the United States House of Representatives passed a resolution, and there is a proposal for a reduction in the commerce budget of $880 billion, B as in boy, billion dollars, of which that is where Medicaid rests. That's the committee that it finds itself in right now, being debated. I believe, one of the most important programs in rural communities. Now, I say rural specifically because there's a disproportionate share, Brian, as you know, of Medicaid patients in rural communities than there is urban.
That's right.
Is that correct?
That is correct.
So the conversation around rural hospital boardrooms probably looks a little different, even though still going to have the conversations, a little different than maybe it does in the urban counterparts. But specifically for rural, as we face this disproportionate share of Medicaid that already was not paying the cost of delivering the service, now we're being told, brace for the storm of our lives. Brian, this is very, very challenging for hospitals that already have no margin, hospitals with maybe a 1% margin, to understand any percentage of cut to a population we're already serving, where we lose on every patient that walks in the door, historically, up until recently, what the work MHA did, but still no margin. We know in this business, no margin, no mission. If we don't make a margin, one of my colleagues at the Michigan Hospital Association board yesterday talked about the importance of the margin, reinvesting back in capital and equipment and those things. This is why we talk about tariffs and the impact of those on us. But talk to us about what's at the heart of this issue right now. What do we expect to happen, and how can we be advocates?
Well, absolutely. And there's a lot to unpack there. Fortunately, as you know, we just yesterday were joined at the MHA Board of Trustees meeting by Rick Pollack, the CEO of the American Hospital Association. And so had a great opportunity to dialogue with him about the latest from Capitol Hill. But let me just set the context first, because I think it's important when we talk about Medicaid, and to your point, JJ, about the differences state to state. Here we are in Michigan, which is a Medicaid expansion state. That's relevant to this discussion because it means that more of our population is covered by Medicaid.
Correct.
And thankfully so. And of course, as you well know, Senator Mike Shirkey was in the state legislature and very instrumental in getting that to the finish line under Governor Rick Snyder at that time.
That's right.
So fortunately, we are a Medicaid expansion state. We are also a state that has a very robust provider tax program that we were successful in moving to the average commercial rate as the new benchmark. I just got that approved for the second fiscal year going forward, which is tremendous. So that's the good news. Also, when you look at Governor Whitmer's budget recommendation for the fiscal year that begins this October 1, and you look at the conversations we've had with leadership in the State House and State Senate, all of the MHA board identified priorities when it comes to the Medicaid budget are all in a good place. So that's the good news. We're starting out from a good place. Now, you talked about what's happening in Washington, D.C., and you painted that picture. I think it's critically important for all of us to make sure that our elected officials understand, and to do that, you have to educate your community so that they are advocating on our behalf. It is not just Medicaid recipients who will lose access to needed health care services if these cuts that are being pondered were to be implemented. It's lack of access for everyone in the community.
Regardless of your payer.
Without question. So once people understand that, hopefully then they will be motivated to advocate on our behalf. And as we always say, politics is not a spectator sport. You have to get engaged. If elected officials, whether they're state or federal, if they don't hear from a particular constituency group, the default assumption is everything must be okay. And so this is the time when we need to make our voices heard.
Agree.
Now, to your point, the House Energy and Commerce Committee has been given instructions in this budget resolution to find these significant savings. At this point in time, on paper, there is no specificity in terms of how those cuts will occur. But the reason we're so concerned, JJ, as you know, is that Energy and Commerce Committee has the oversight of Medicaid, and there's literally no way to get to $880 billion without making significant Medicaid cuts.
Drastic cuts.
And so things like changes to that Medicaid provider tax program, things like Medicaid work requirements, things like per capita caps, things like moving to a block grant approach. All of these things we know are on the table and are being discussed on Capitol Hill right now, even if that hasn't been subject to a formal committee hearing or a vote at this point. As Rick Pollock shared yesterday, we're probably only in the top or maybe the bottom of the third inning of a 9-inning baseball game that could very well go to extra innings.
Yeah, it could.
And so even though there's been a lot of angst and a lot of activity in D.C., there's a lot of work ahead of us. So we can't give up hope. We have to continue the very hard work. And as I said, make sure our elected officials are hearing from us and they're hearing the right message, which is this is threatening access to everyone in the community, not just Medicaid recipients.
Yeah, I absolutely wholeheartedly agree and wholeheartedly appreciate the work that MHA is engaged in, the work that your team is doing in advocacy. Brian, I'm texting every day now, your team. But, I want our listeners to understand. I want to paint a picture. Hillsdale, Michigan, 50,000 residents, 70% of my payer mix, 70% of the people that walk through my doors and that walk through my clinics are government payers. Right. And a removal of any percentage of those, when we already have a razor-thin margin up until just a few years ago, and that's been because of some of the growth we've had here and bringing new providers and services and going out and, much like you, doing new ways of engaging businesses. We had no margin, but up until recently, a very thin margin. But you remove any percentage, even 1% of the reimbursement that we're already getting to take care of a population that is in rural communities the highest, generally speaking, payer mix in rural. Medicaid will be devastating for hospitals. Now, what we're talking about is your organization did some modeling for me. I asked Jason and the team, say, all right, what is this going to look like for Hillsdale if we take a rollback or a cut? We did some various modeling. At the low end, $6 million, top end, $11 million. Well, Brian, $6 million, all right, of $90 million and $11 million of $90 million isn't just me eliminating paper clips and pencils and laying off a few people. These are programs to the point where you cut so deep to the bone that it impacts all your other service lines, ancillary, downstream revenue, et cetera, where you're closing meaningful programs that historically have been community benefits, such as obstetrics. It's the first to go. It is across the country right now. Mental health services.
These are real impacts, JJ, that you're talking about. It's why we have to prevail here. We have to continue to advocate. The good news here on the political front, just to get into that for a moment,
please.
Is that here in Michigan, obviously we have a Democrat governor. We have 2 Democrat senators, okay? We do have Republican members of our House delegation. Right. And I'm raising this because, of course, we have the Republican trifecta in D.C., Republican president, House, and Senate. Yeah. And so as these cuts are being pondered, who is the White House most likely to listen to? Well, potentially a Republican governor in a state that has similar concerns to what we've been discussing here in Michigan, who will say, Mr. President, this change to the Medicaid program will blow an enormous hole in my state budget that I can only fill with massive state tax increases, and I sure don't want to do that. So hopefully that message prevails. And then on the U.S. House side, remember, the margin now is razor thin. And there are quite a few folks on the Republican side who were elected last November in marginal districts who are looking at public polling, thinking ahead to the midterm elections next year already, and thinking, you know what, given the nature of the politics in my district, I got to be pretty thoughtful about how we proceed here. And so just talking about the politics I think is important, understanding that backdrop here. Again, at the end of the day, we have to keep our messaging at a high level.
We do. Let's peel back one. I'm only going to peel back one layer of the onion today, all right? And that is we keep hearing fraud, abuse, waste. I don't think there's anyone that's listening to this podcast across the country that would say, we want fraud, abuse, and waste. Everybody wants it eliminated. There's not enough fraud, abuse, or waste in the system today to get to that number or even close to that number. If anyone knows the difficulty of making application for Medicaid and getting accepted to Medicaid, the verification process, that you have, income met and that you have, assets, and that all of those things are evaluated, scrutinized, bank statements, you name it. It's not just as if you can just get on today and say, I'm going to get Medicaid and I'm going to lie and they're not going to prove it. So are there some bad actors out there? Of course there are. But you cannot take the few bad actors and put them on our shoulder and carry the rest of this by gutting that service. So fraud, abuse, waste, we all would support the elimination of that. But that's not what we're talking about, Brian. What we're talking about is cuts to health systems and to providers. Can you talk a little bit about that? Because you're going to hear a lot of news clips saying, we do not want to cut Medicaid. We are not cutting the Medicaid program. And they're right. They're not cutting the Medicaid program, but what are they going to do if this happens?
Well, you're exactly right, JJ. And to the extent that there are providers that are fraudulently billing the Medicare or Medicaid program, those folks should be prosecuted to the fullest extent of the law. But you're exactly correct. There's not enough of that in the system to make up for these numbers that we're talking about. So here's the real crux of the issue. And it comes down to how are members of Congress defining fraud and abuse. Unfortunately, some on Capitol Hill would define our provider tax programs that are utilized in Michigan and other states as fraud and abuse, as ways to game the system.
Right.
I would push back strongly on that notion because the reality is we've created a program that was designed to ensure that we could generate the appropriate federal match to adequately compensate providers who are for years and years providing 24/7, 365 care to Medicaid recipients at payment levels that fell well short of the real cost of
Extremely
care.
below.
We have done everything we can to cobble together an approach that helps make us whole or gets us closer to whole. And I would also point out, these provider tax programs are utilized by virtually every state in the country to some degree or another, and they've operated effectively under both Republican and Democrat
vetted
administrations.
Underneath both administrations.
Fully vetted by CMS under Republican administrations and Democrat.
That's right.
So this is a program, I always say, if you were to wipe the slate clean in American healthcare financing and start over, would you design the system we have now? Well, of course you wouldn't.
Right.
But the fact that we have all of these programs in place, it's created an ecosystem, right? And if you pull out any one of those levers, you risk the entire structure collapsing.
You sure do.
Unless there's an incredibly thoughtful way to modernize that element. And what we're talking about here is not that.
Not at all.
We're talking about slash and burn, and that just cannot happen.
Well, later today in the studio, I'm going to be joined by Scott Becker. And of course, you attend Becker events, and Scott's a great friend of mine and a great advocate of healthcare. And Scott, recently, seems like every day we get an email from Scott and the Becker's News talking about hospital closures and the impact of hospital closures in rural communities. For Hillsdale, third largest employer in the county, second largest in the city, contributing back tens of millions of dollars back into the local economy. Devastating if a hospital's closed. But Scott Becker recently published some work that was done and demonstrated that over 580 hospitals would close. Of those, the majority of them, Brian, at immediate risk of closure if this goes through. And just think about, let's take away the greedy administrator's hat about the finance of it. Let's talk about access to care. It's gone. And that's the biggest concern, what we're talking about. This is where we have to humanize these issues. We're talking about, I'm a product of Medicaid. There were 7 children in our family. My father was shot down at the end of World War II, came in at the Korean conflict. His plane was shot down. My father was injured. My father tried to work, but he physically could not. He made $86 a month from the VA. My mother, upon birth of me, 7th child, was told that if she delivered me, that she would surely die. She had complications from my delivery that caused her pain the rest of her life. And so we were a product of Medicaid. I am not a face of abuse, fraud, or any type of phraseology that someone wants to put on abusing the system. We needed it. It was access to care. And what we have to remember is in rural communities like Hillsdale, there's the JJ Hodshires out there every day whose parents have mitigating circumstances, issues that they're facing. It's the worker at the gas station making $12 an hour, taking care of 3 children who is not, first of all, even offered insurance because they're under 50 employees. And number 2, can't go out on the marketplace to get that insurance because of the poverty rate in which they are located. So we have to be reminded every day that what the faces of Medicaid look like right here. Now, we're on a podcast. They can't see my face, but I am a product of Medicaid. I know the value of Medicaid for my family. My brother was a brittle diabetic. He needed services, health services. I needed health services growing up. Without that product, I don't know where I would be today. So we have to be mindful of the human side of it. And it's the right thing to do to care for those among us who are the least among us, those who are the most in need, and absolutely get rid of the gamesmanship, get rid of the people that are going to abuse it or creating fraud. But the hospitals are not creating fraud. We're using programs that exist that are allowable by the law just as much as I can claim all 4 of my children when I could on my taxes. It was allowable. I did it. It's not a loophole. It's allowable. And just like we are maximizing some of these programs to try to get back the most reimbursement we can. And even when we get that back, in many cases, Brian, it doesn't even cover the cost of delivering that service with the rising wages that we have, the rising supply chain. Just imagine now what tariffs are going to do, all the competition in the marketplace. Bottom line, the faces of Medicaid are what we have to be minded of.
Well, that's right. And as it turns out, the MHA and many of our members are strong supporters of the Coalition to Strengthen America's Healthcare. And the Coalition is now running advertising around the country, particularly in key media markets. And the theme of that advertising is exactly as you said, JJ, the faces of Medicaid.
That's right.
And it's really painting a picture that hopefully corrects this misperception that some elected officials have about who qualifies for Medicaid and who relies on Medicaid on a daily basis. And it's children, it's veterans, it's farmers, it's people that are friends, neighbors, co-workers, loved ones. It is just a critical program for many people. And that's what we have to keep front and center.
We do. All right. So if you're listening today and you're in a rural community, your hospital, your providers at risk with this very dangerous proposal to cut Medicaid drastically. Yeah, you may have in your community Medicaid patients who have that Medicaid card in their purse, in their wallet, but unfortunately there will be no place to use it in the nearby area. I'd encourage you, speak out. Brian, locally in the state of Michigan, there's a way to do that. You can access a portal. You want to talk a little bit about how someone can advocate against this?
Well, absolutely. The Michigan Health and Hospital Association has developed a website where you can actually go through MHA.org and the My Care Champion page. Very easy to find and navigate. All you have to do, JJ, is plug in your home zip code.
It's amazing.
And it will direct you straight to your elected officials, both the state and federal. You have a pre-populated letter that has information, our talking points about the issue. So it couldn't be easier to get engaged. We know that thousands of our colleagues have already utilized that site, which has been operational for some time now. So we would encourage you to visit www.mha.org.
Thank you, Brian Peters, for joining us today. It has been a marathon session in the studio, and this is the longest I've ever kept you. I promise this will be the longest that I ever keep you, but these are issues that are impacting Americans across the country. Everyday issues that are so important for us to advocate for and against in certain areas. And your leadership at the helm of, I would say, one of the best hospital associations in the country. I heard that just the other day. I won't tell you who told me that, but someone very important told me that and said that we are the best association. I would agree with that. But it really goes back to your earlier statement. It's all about leadership, and that's because of you, Brian Peters. The work that you've done. If you leave, we're just going to follow you. So you're not leaving anywhere. You're going to stay right here in Michigan, working hard for Michigan hospitals, engaged as you are in the leadership of your team. You trust them. You give them the opportunity, but you also set a direction that's so important. Every time we're together for every year, strategic planning, it's powerful to watch how you work, how the team works. But you get around the hospital association board, and we're having open dialogue about things that matter to our community and ways in which we can help each of the consumers in our rural and respective areas. Not all rural, but I speak for rural, and I think that's very important. So Brian Peters, thank you for joining us today. You've been a phenomenal guest. You've stuck it out here in the studio. But thank you for the work that you're doing. I want to come back in a few months, maybe just give a great story. Maybe some updates to these, like, hey, yeah, we got that through. This happened, that happened. And would you take that challenge on?
Let's do it.
All right, Brian, thank you so much. So we'd like to wrap up our new closing segment in Rural Health today with Rural Health recommendations. So for every guest that we have on the show, we ask them to contribute a recommendation on rural life and healthcare. Brian talked earlier today about his rural life on the boat, on the charter boat, and in a very rural part of our state of Michigan. But Brian, I want to go a little deeper. It could be a tip that I want you to give for someone who is working in rural health today who may be discouraged. Maybe you can give them some sage advice about, for such a time as this, they've been called to lead, whatever it is. But something that they can grasp, like is there hope? Is there a sense of a better tomorrow? Or what advice would you give them, sage or otherwise?
Well, I appreciate the question, JJ. And I think about my own personal life and, the stress that comes with the job. And I always come back to how fortunate we are to have access to so many rich resources in rural Michigan. Now, for me, it's a 3-hour drive up to my home ground of Charlevoix, which I love. But for folks who live and work every day in rural Michigan, take advantage of that. Get outside, walk on a nature trail, hop on a boat, do something where you're in the great outdoors, because there's something calming and centering about that. I can't tell you how many of the really impactful decisions that I've made occurred in those moments when I was able to clear my head and have some of that time outside. That's really, really important in my view. Rural Michiganders have ready access to that opportunity, so take full advantage.
Yeah, they do. And I was speaking with a colleague of ours, Dr. Yara, and she was sharing with me that she rides horses. Mm-hmm. And I said, when in the world do you find time with a son that's in major sports and, busy life, running a hospital? Do you find time? She says, I have to make time, JJ. And a few days a week, just for a half hour, 40 minutes, I ride around the farm, and it clears my head. I can focus. And I think that perspective is so necessary. So to your point, enjoy the rural nature of Michigan. Brian, it's been a great pleasure to have you today on the podcast. I look forward to having you again. Thanks for joining us.
Thank you, JJ. Always a pleasure.
And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health care every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so that you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.